to traditional owners of the land on which we meet, the Ngunnawal people, and pay my respects to the elders past, present and emerging. I'd also like to acknowledge that it's Closing the Gap Day today, and I'd like to say that it's our doctors, our members that are on the front line out there, working every day to close this gap and to really close the gap. To truly close the gap, we need to get rural health right. And what we're doing here is building programs and systems and advising government to try and make that a reality. We have a very large gathering of rural health industry leaders here today. Thank you all for coming. We really appreciate your support and interest. I'd particularly like to thank the Deputy Prime Minister Michael McCormick, Ministers Hunt, Coulton and Tehan for coming today, and the Shadow Minister for Health, Chris Bowen. Also former Leader of the Greens, Senator Richard Di Natale. It means a lot that rural health is recognised as an important aspect of the government's work from both sides of the House as well as the minor parties. It's an exciting time for us with the implementation phase of the National Rural Generalist Pathway now underway. And work has started with the colleges towards formal recognition of rural generalism as a specialty in its own right. Those of us who have worked in the bush as RGs know just how important it is, how important this specialty is in the provision of health services to rural areas, and also to recognise the irony of generalism being a specialisation anyway. But it really is. Rural generalists really are the specialists in rural health care. We ensure the medical needs of our communities are being met, and to keep the RG career path attractive, we need this recognition and the supports that come with that. We welcome the government's commitment in this area to develop the National Rural Generalist Training Pathway, and are very grateful to hear today that the additional 100 Rural Generalist training places will be allocated to ACRM. RDAA has advocated strongly for this outcome, and we are really excited that the government has listened and allowed these places to go to the college that will make the absolute best of them. These positions will enable ACRM to expand their program into Victoria, Tasmania, WA, South Australia and the Northern Territory. But as Chris said, the clock is actually ticking. Every month we see more rural GPs and specialist generalists retiring, and the pipeline of doctors to step in to take their place is failing. What many of our members have seen as the saviour of rural healthcare, that's the Rural Generalist Pathway, has felt like it's stagnating in the corridors of the Department of Health. We've been asking for urgent action on the pathway. We've been asking for urgent action on the pathway since its announcement. It's a fair while, it's over 18 months. However, a lot of work has gone on behind the scenes, and we're stoked to see the real progress towards the implementation of the RG pathway announced today. But for the National Rural Generalist Pathway to reach its full potential, all of the recommendations need to be progressed. Rural doctors are yet to see action at the coalface. We are deeply concerned about the impact this is having on the rural generalist workforce crisis. There is a significant lag time once training begins. It takes a further 5 years from the completion of medical school to graduate a fully fledged rural generalist doctor. Every month that goes past is another opportunity missed. If we miss the implementation date at the start of the calendar year, then a whole year is lost and the program is put back another 12 months. We are reaching a crisis point in the rural doctor workforce shortage now. Birthing services continue to be the most obvious casualty in this war of attrition. Just in the past few months, we've seen Ceduna Maternity Service go on continued bypass. Yarrawonga birthed its last baby a few weeks ago. Forbes and Parkes are in the process of consolidating their maternity units, and the Chinchilla Birthing Service in Queensland is still closed. And before you think rural generalism is all about hospitals, it's not. For viable and efficient rural medical services in both general practice and in hospital care, it is essential that these services are integrated. There are examples when the rural generalist model is used well. Not only do procedural services become accessible to rural people in their local hospital, but increased access to general practitioners is the result. General practice is the core element of the rural generalist model. It also provides, as previously touched on, another opportunity for other community-based services such as mental health, palliative care and pain management to grow. The recommendations to implement programs, but also to provide the supports and systems to embed and sustain rural generalist practice are there for government, and we are stoked about the announcement today that see these recommendations finally becoming a reality. RDAA always tries to take a solution-based approach to our challenges. We invested significant time and resources to work with the National Rural Health Commissioner, Professor Paul Worley, to develop the recommendations in the National Rural Generalist Pathway Advice Paper. The solutions are there. Recognition and industrial reform are required to progress the rural generalist pathway. Innovative employment models will be required to ensure this becomes a reality. A great example is the single employer model, particularly local solutions such as Murrumbidgee, which we've heard about today, and we're excited to hear from the Minister that this trial has finally been given the tick of approval and funded. RDAA and its junior doctor members in particular have been strong proponents of this model. With solutions in mind, the recent bushfire crisis has put our emergency response into the spotlight when it comes to the coordination of doctors in disaster-affected areas. Too often in rural areas, the skills of GPs and the rural generalist doctors trained in emergency are overlooked in disaster and retrieval situations. During the recent bushfire crisis, we received multiple reports from members about GPs and RGs being overlooked or worse, actively excluded from the emergency response. This cannot go on. Once the ash is settled and the smoke is cleared, we need to put mechanisms and plans into place to ensure that future response is improved. We can always do better. We call on the government to act and establish a national register of suitably qualified rural generalists and general practitioners who can be deployed in the time of crisis, but also called upon throughout the recovery period for these communities. South Australia has an excellent system, the Rural Responder Network, and it could be used as a template for other states to roll out a similar program. It is in between crisis times that we need to reflect on what we can do better and develop the systems to ensure past failings do not occur again. It is clear that systems need to link local GPs into the emergency response, as well the backup supports that these communities require in an ongoing sense. Of course, that's assuming we have a cohort of suitably trained rural doctors on hand to call on in the future, because training and filling rural positions continues to be a major problem. At RDAA, we are doing what we can. Since June 2019, we have been running our Destination Rural project. With funding from the Commonwealth Department of Health, thank you to the Workforce Division, we have been extremely busy with activities to lift the profile of rural careers. We have attended 15 events and many more in counting. We have run 4 webinars with over 200 engagements and had more than 650 Twitter mentions of Destination Rural with a reach of over 450,000. We've produced 4 short videos promoting different aspects of rural medical careers, like the one you saw earlier, and they've been viewed in well excess of 1,000 times, and there's more on the way. We're working hard to show young doctors the exciting and vibrant training opportunities in careers and lifestyles that await them in rural Australia. Again, a massive thank you to Minister Hunt for announcing today that this program will be funded again for another year. Destination Rural has made such a difference to the profile of rural medicine. There is so much more to do, and we're excited about the interest and level of engagement the project has received with young doctors. However, there is no point in building excitement around a rural medical career if we can't provide an attractive training pathway. With GP training being handed back to ACRM and RECGP in 2022, RDAA calls on both colleges to do things differently. We call on government and the Department of Health to support the colleges to develop new, innovative ways to deliver their training programs while retaining a commitment to rural and remote communities by delivering a workforce with the skills to meet their needs. In the meantime, we particularly call on the regional training organisations to step up and just do your job. Work towards actually meeting your targets and rural placements. There is not one RTO in this country that has met its target for both ACRM and RECGP rural pathway training positions in 2020. We know in recruiting junior doctors, we're in a very competitive career market. RTO-based GP training needs to step up its game. More of the same is not going to cut it. With the establishment of the support and coordination units under the National Rural Generalist Pathway, early training and career planning will help to ensure that doctors who train in these areas can then be ready to take the step into other rural communities at a stage when they are competent and confident to practice clinically. It appears that the RTOs play a role in creating some barriers that go beyond the requirements of the colleges. They can be prescriptive, heavy-handed, and create an environment of non-self-directed learning with a sometimes paternalistic approach. For rural registrars, this approach is quite confronting, and it adds to them feeling unsupported and, unlike their city colleagues, often found training in a practice or a community often as a sole registrar. If we want a viable future for rural healthcare, we need to make sure that rural medical career path is accessible, viable and attractive. RDAA is strong in the belief that rural medicine, rural generalist medicine, is not better than city-based general practice or other city-based specialties, but it is different. The clinical load, the work hours, the expectation of the community and the skills a rural doctor needs are all different from what our metro colleagues and those based in large regional centres experience. And I can tell you firsthand because I've worked across all of those different models of care. The clinical, no, it's not better, but rural medicine is definitely different. The RTOs, the RACGP and the non-GP specialty colleges need to recognise this as a fact and align their training, their marketing and their message to support and assist the next generation of doctors to choose rural. So with the recent media attention on the GP bulk billing incentive changes and that some locations are now missing out, RDAA believes for the most part this is a necessary correction in the system. The fact that Canberra general practices now don't receive the rural incentive, well, we think that's a good thing. Rural incentives must remain true to their intent and not be used as a mechanism to address other deficiencies that exist within the general practice funding model. So, finally, we thank you all for coming today and we hope that you will now take the opportunity to talk one-on-one with the people at your table who can answer your questions and share their experiences of rural health. Together, we can build a bright future for rural health and rural Australia. Thank you.